People have been migrating since the beginning of time. It is only in the last 100 years that migrating without proper permission has been considered a crime. While in theory we have become selective about who and how many can migrate into our country, the reality is that the number of U.S. immigrants grew by more than 40% between 1980 and 1990. As of 2009, of the 307 million U.S. residents, 28 million were legal and undocumented immigrants. Most immigrants with green cards, that is, those who are here legally, are not eligible for Medicaid for the first 5 years in the U.S. The Personal Responsibility and Work Opportunity Reconciliation Act in 1996 is responsible for this change. Consequently, someone like Antonio Torres, a 19-year-old uninsured documented farm worker, was repatriated to Mexico after suffering a traumatic brain injury. He was comatose and connected to a ventilator. The same policies that have tightened the documentation requirements for obtaining Medicaid coverage have also restricted or forbid the use of public funds for undocumented individuals. The Emergency Medical Treatment and Labor Act requires hospitals who accept Medicare to medically screen all individuals seeking emergency care regardless of their resident status or ability to pay. Undocumented immigrants receive unequal treatment compared to Medicaid recipients, fewer procedures and tests performed, and shortened length of hospital stay for similar diagnosis. For undocumented immigrants, accessibility to medical services is low, and most of the time they have to pay with cash for health services. There are other barriers to accessing health care for this portion of the population. Hurdles include language deficit, 3/4 of undocumented immigrants do not speak English, lack of knowledge to enroll in public insurance, an inability to maneuver the public health system, fear of debt, and long lines. Fear of being reported to immigration authorities results in a decrease in receiving medical care. So what's the ripple effect? While federal statute mandates emergency care and limits this care by excluding only organ transplant, they refuse to fund other emergency services hospitals are providing. The task of defining an emergency is being left to states, not healthcare providers, creating a potential for unethical and neglectful treatment by hospitals. Withdrawal of federal support for immigrant health coverage shifted the burden of covering this population to states and local safety net providers. States with large immigrant populations already have in place state-funded coverage, but their funds are limited. States that previously had low immigrant populations lack provisions, while the number of undocumented and uninsured immigrants is increasing. Denying access to preventative care increases the public's likelihood of exposure to medical conditions. Undiagnosed and untreated tuberculosis could cause an epidemic. Seeking treatment in late stages of disease history, as undocumented residents are shown to do, increases cost. So what are the potential solutions? Instead of penalizing those who are here with laws that limit healthcare access, we could create legislation that addresses healthcare discrepancies and immigration issues more comprehensively. Another potential means is giving undocumented residents a voice in the healthcare reform debate, since they account for 17% of the people in the U.S. without health insurance. Their children represent another 4%. The U.S. Department of Health and Human Services attempted to address this increasing health disparity with its health promotion and disease planning document, Healthy People 2010. Its two goals were to increase health and quality of years and eliminate disparities by 2010. It's 2011. We have much work to do.